GCS is included in this, but not in the title because I'm eccentric like that. So in case any of you don't know me, hi, I'm Benji or Ben, whichever you prefer, I don't mind. Second year, and I'm here to talk about consciousness and head trauma. And generally, we're going to have a lot more of the open questions towards the start, and from then on, we won't have as many things where you might have an open-ended answer to give. So please try to power through it at the beginning. Remember that this is going to be provided to you afterwards with the full slides with a few hidden ones with a bit of extra goodies that you might find useful or interesting later on. So don't feel any need to take any strenuous notes at this point. This is just really getting the main points across and getting the main principles you need to think of going forward through, and the actual information itself can come later. Okay, so when we're talking about consciousness and head trauma, probably should start talking about consciousness first, and this is going to be a controversial definition, and a definition that, to be honest, has been debated up to this day and still hasn't quite been decided. But for our intents and purposes, can anybody tell me in the chat what is consciousness, or what you think consciousness is? Yeah, perfect. So it's a state of being aware and awake. So we're getting immediately this binary idea of the fact that consciousness is a combination of two distinct factors, that being arousal or awakeness, and awareness, the ability to experience things. We need to be aware when we're talking about degree of motor function and ability to experience things, that degree of motor function doesn't just refer to any kinds of movement, but it also refers to reflexes and autonomic function. These are also factored into arousal and degrees of arousal, as we can find it. Similarly, experience isn't just having sensory function, like, for example, reflexes must work on, but it's also the ability to subjectively perceive things and comprehend things, which provide parts of our scale that are going to be moving up. So we're not just thinking about the most basic functioning of nerves, but we're also thinking about more the higher order of how these nerves interact with each other in the brain itself. So the next of the two, and thankfully last open questions that we've got is, can anybody give some examples of things that can affect consciousness? I'm sure, as we're all students here, that there's one in particular that should be jumping out at us. Not the one I meant was alcohol and drugs, but that is definitely one. Trauma, exactly. Yeah, perfect. Sleep, thank you. Somebody said it. I was worried for you guys, really. So we do have a list of things that can affect consciousness, and we can largely, if we're trying to remember what these things are, in the grand scheme of things, and if, for example, if you had a short answer question where you had to list 5 reasons for consciousness, we can divide them down into things that disturb structure and disturb the function of the brain, or preserve the structure or disturb but to disturb the function of the brain. I'm seeing LT workbooks. Have they really improved the LT teaching suite since I've had to do that? Wow, I am somewhat jealous. So we've got hypoxia listed as both here, simply because structural changes can cause hypoxia, or hypoxia can occur without any kind of notable structural change. Similarly, we've got metabolic derangement, which can refer to not just hypoxia from the blood, but also from such things as electrolytes or lack of glucose sources. Tumours and traumas are obviously going to be our main disturbing structural examples, and of course we have an entire section for trauma later on, but we'll come to that when we need to. So let's start with how we assess consciousness, and a lot of you might have been familiar with AVPU, which is the scale often used in very short-term emergency situations. So this is going off on a scale of alert, verbal, pain, and responsive, and ideally you want all patients to be alert. There are some scales that you'll find in clinical practice that include a C for a new confusion. I'm telling you this so you should be aware of it if you find it, not so that you should remember it for the exams. That's not going to be helpful to you. For purposes of your knowledge, AVPU is definitely sufficient at this stage. But of course, this is a simple method that's good for emergency situations and fast-paced evolving situations. So we need probably a more complex system. This is going to be our notorious GCS, the Glasgow Coma Scale. So it's important to remember when looking at the Glasgow Coma Scale that all of the three domains, they're not evenly scored. The eyes are going to have 4 points at a maximum. The verbal component will have 5 points at maximum, and the motor component will have 6 points at maximum. And there's a lot of jargony type terminology that's used to describe some of these. So we can go down the eyes, open spontaneously. They can open without having any outside input. They can move about based on conscious will. They'll open to speech, but won't necessarily be able to move as directed by the patient's own wishes. They might open to pain, but not respond to speech itself. For pain, please use the trapezius twist. Don't do that sternal rub thing. And of course, at the lowest score, there is no opening whatsoever. Similarly, with the verbal component, we've got a score of 5 for oriented time and space. Confused with disoriented speech, but still speech that is actually making some sort of grammatical sense. Inappropriate words, where the patient might not be able to find the right words to actually use for it, and incomprehensible sounds, moans, sighs, groans, before we get to no sound whatsoever. Now, motor is where a lot of our more specific jargon comes into play, because the highest score of 6, of course, would be obeying commands. The 5th one would be localizing to pain, and a lot of that can be described as being reaching towards or identifying an area that pain occurs. We also have withdrawing from pain as the next score down at number 4. And then we find the 2 that are quite specific in their jargony terms: inappropriate flexion and inappropriate extension to pain. And there is actually a specific posture of the body that is thought of when we describe this. Decorticate and decerebrate posturing, they're called in some literature. These are named because of brainstem lesions that can cause them in different locations. And to be honest, this kind of terminology is probably best avoided because it implies a particular clinical finding. But nonetheless, the terms still persist in some literature, and you may spot it. So when we're talking about inappropriate flexion, we're talking about the so-called mummy posturing, where the arms come in towards the body, the fists curled up on the chest, and the feet will turn inwards. Personally, I like to think of this more like a T-Rex, but that's just me. That's how I remember it. The cerebral posturing, of course, is the opposite, which we see extension, and this will usually be arms turned out along with the hands turned out. Fingers also will be uncurled because extension, and feet will often be in a variety of other different positions other than the turned inwards as you can, depending on what the patient is capable of physically. So it's quite hard sometimes to draw a distinction between inappropriate flexion extension and localizing to pain. The general rule is that a patient who is inappropriately flexing or extending isn't expected to be able to lift their arms above the level of the sternum. That's a very rough estimate, and there's a lot of gray areas for it. But generally, when you're talking about GCS measuring, you're going to be using these kind of postures as your reference for that. Just a small point. Can anybody tell me what the GCS of this wonderful 3-leafed shamrock is? 3. Thank you. I know that it's a wonderful, much-loved MCQ trick question to provide a whole set of GCSs with the scores of 2 and below. Hopefully the memory of me haunting you like the ghost of Christmas past will prevent you from even considering those, because the minimal GCS that you can get is always going to be 3. There is no score lower. And some people like to use a brick for this example, but hopefully you'll remember the 3 leaves, the shamrock. Who knows? So now we're going to have some practice with GCS measuring using a film that shall not be named, Pulp Fiction. Okay, I just broke my own rule there. As our examples. So from the start, we've got our baseline here. We have Mrs. Mia Wallace, age 34, wife of a known crime lord who has suspected to have taken an overdose of a recreational drug that shall not be named in this case. So her eyes are closed, and even while someone's tapping her sternum roughly, she's also making no sounds of any kind, and there is no voluntary movement from her body. There's no involuntary movement from her body except for the recoil of the tapping. So what is her GCS at this point? Yep, it is. It is indeed 3. Thank you, Katie. So at this point, we are going to say her GCS is 3 for all intents and purposes. But of course, the situation develops quite quickly. I know you say super quick. We're going with the stills from the film itself, which are not exactly medically accurate, which is why I'm not naming most of the supposed drugs being used in this, because honestly, adrenaline doesn't work that way. It's surprisingly not as difficult, but it's still not not as it's meant to be. But in any case, we're going to move on to the next part where she's received an adrenaline shot from a very underqualified mobster who's been looking after her for the evening. So she's currently howling and sobbing in pain, but she hasn't spoken, as far as we know. Her arms are out and flailing around, so they're definitely not flexing towards the syringe embedded in her chest. And her eyes are wide open, but they're just staring into space. They're not looking on anything. They're not responding to a sound. They're simply opening in response to the pain. What would we say her GCS is at this exact moment in time? I'm getting 8. Some might say 6. I would say 6. But I can definitely see why Katie would go for 8 in this case. And to be honest, there's a large part of this is intentional, because one of the ambiguities of GCS is that at any one moment in time, you're going to get an inaccurate result depending on what you observe. So GCS is only really reliable when it's being observed over a continuous period of time. And the longer you're observing a patient in this case, the more accurate your GCS is going to end up being. And if you have a smaller time frame in which to assess it, you're going to end up with a less accurate one. And finally, we're going to move on to the aftermath of this mysterious one drug that's been embedded in her chest. She's now pulled herself to her knees. She's gasping. Someone asks her, if you're all right, then say something. And of course, being, as this is a Quentin Tarantino film, she says something. It's a pretty funny joke, if you ask me. She's reaching towards the syringe, but she still hasn't shifted from the position. So at the moment, we don't know if she can obey conscious commands, and she's staring quite purposefully at the syringe, which, to be honest, I can't really blame her for. So what we say her GCS is at this point? I would say it's 14 personally. So I'm agreeing with Camilla there. I'm curious as to where you calculated each component, Rosie, because I can see how you might actually come down to that particular opinion, especially on the motor domain, where it's not sure whether her flexion is entirely conscious or not. Yeah, okay, that's fair enough. There is, but like I say, there is ambiguities, and this is a major learning point with GCS, is that it's not really any more perfect than the ability to assess of the person providing the assessment. And there's going to be a lot of inaccuracies as it develops and updates as the situation evolves throughout the entire time of the patient being cared for. So there is the hidden slider with those in full. I'm briefly going to go over the neuroanatomy of consciousness, and I say briefly because this was a hidden slide in our cohort. I'm guessing it was probably the same in yours, and to be honest, there's not really as much to teach about this. because the reticular formation is poorly defined. And by that, I don't just mean that scientists have given us a very bad definition of it. I mean, the reticular formation is a scattered mess of nuclei dotted throughout the brainstem entirely. So these are a few of the ones that you might hear about. And there are others involved, of course, but these are the main ones that were mentioned on that hidden slide. I would have liked to have found a diagram for it, but unfortunately, my friend supplied a semi-conscious teddy bear rat, so we can thank them for that instead of having the diagram. But in essence, be aware that there is a reticular formation that controls consciousness. If you can, maybe try to recall one or two of the major components for it. But don't expect to understand it, because most neuroscientists aren't entirely sure about it either, for that matter. So now we can move on to looking at head trauma, but first we need to start with some definitions of what we're talking about. So when we're talking about ICP, we're talking about the average pressure within the cranium. It's pretty much in the name. That's usually 5 to 10 millimeters of mercury. And we're talking about that in response to mean arterial pressure, the average pressure within the arteries, and cerebral perfusion pressure, the net pressure of how oxygen is delivered to the brain. Put simply, the amount of oxygen that the brain gets is the amount of oxygen that's circulating in your arteries at any one time, minus the pressure of whatever is already in the skull, which kind of makes sense when you think about how pressures work as far as we remember from block 2. Oh, block 2. But we also need to consider something else when we're talking about head trauma, which is the Monro-Kelly doctrine, which is basically a further extension of this idea of pressure, which is stating that the internal volume of the cranium is fixed, it's constant. And this was called the Monro-Kelly hypothesis before it was evidenced by experimental studies that the cranium does indeed have a approximately fixed volume, which is now why it's now in the doctrine instead. But in essence, the doctrine states that because the volume is fixed, if you increase the volume of some of its contents, other contents will decrease in volume. And this is just generally true of anything that will introduce new material or new mass to the skull in any way. There's a slight difference of this when it comes to head trauma, which you might find an open fracture, but we can move on to that in due time. There's no need to rush into that at this point. So when we're talking about bleeds, we might refer to the extraaxial ones and the intraaxial ones. Extraaxial ones being outside of the neural tissue itself, and intraaxial ones by association being within the neural tissue itself. So we're going to start with the first one. We've got this very characteristic ovoid shape. So it doesn't really seem to be following any of the sulci or gyri of the cortex. And it seems quite dense as far as we can see at this point, because it's quite bright on this wonderful MRI. So can anybody tell me what kind of bleed this is? Exactly, extradural or epidural. Both of them are perfectly valid names, which of course we can see here. We can find that it's being limited by the sutures of the meninges to the calvarium itself, which is why we're seeing this limited ovoid shape that doesn't really follow the shape of the neural tissue or the cortex, because it's in essence being packed into a space where it's already got to obliterate that just by nature of how it's accumulating. So this is usually going to be our arterial bleed, simply because that's usually the area where the middle meningeal artery runs through. You can find venous ones, but this isn't exactly guaranteed by any means. Next, we've got a slightly different one. This is going to be on the left side of the brain, so image right, as we might remember from anatomy. This one, instead of being quite so concave, is a lot more convex, and there is some following of the shape of the cortex, following the gyri in shape somewhat around. And this one at this point is not as dense. In fact, it's less dense than the tissue surrounding it. So what kind of hemorrhage is this one? I'm seeing subdural. That's exactly what this is. This would be a subdural hemorrhage, which is the one below it. And yes, I've seen some people clarifying that it's chronic. That is absolutely on point. So you will find, of course, in an acute subdural hematoma that it is a lot brighter on MRI. It's a lot more dense and will gradually lose density over time as it goes on. I'm curious, does anybody know if you have an isodense stage, so the point at which the subdural hematoma is exactly the same density as the surrounding tissue, how would you try to identify it on imaging? There is a hint on the image itself, I should point out. Yes, you can do one instead. So you might be looking for, in this case, so I'm seeing some pretty good examples. So you might see loss or size of the lateral ventricle. You might find midline shift, or indeed, as Rebecca says, you might find that the sulci on the opposite side are effaced, in essence, flattened out, lose some of their shape and definitions. So there's lots of other hints structurally that you can use when you're looking at an isodense subdural hematoma to describe that. And finally, we've got our last kind, and we can see that this also in the left side of the brain is not really surrounding the brain in the slightest. It's embedded within the sulci themselves. It's quite dense. Any ideas what this might be? There aren't that many options left on the diagram of the various meninges above. So it is indeed subarachnoid at this point, which would be, of course, below the arachnoid layer of the meninges. So this is usually characterized by a very sudden onset and a what we call a thunderclap headache that rapidly appears at very severe rates. This is quite a bit harder to treat in some ways, very similar to the next one that we're going to be looking at, which is not an extraaxial bleed, because it will be, of course, embedded quite deep down and might be even spilling out into the ventricles, depending on where the bleed is located. And of course, unlike the other two examples that we've given, this one isn't found in cases of trauma as much as it is found within aneurysms that do rupture over the course of time, simply because of how deep to the tissue they actually are, by comparison. There is actually a very small category of subpial bleeds, which you do not need to know anything about. There is a hidden slide here if you are curious about that, but this is, for all intents and purposes, not something that you'll ever find. If you see something that you're not sure whether it's subpial or subarachnoid, in an exam, it's subarachnoid. Definitely going to be each time. And of course, there is one example that we need to look at, which is more of a entire class, which is what we call intraparenchymal bleeds. Parenchyma simply refers to the main body or mass of any one organ. So in this case, this would be the neural tissue proper. And you might find different names depending on where it is located. So within the cerebrum, intracerebral, intraventricular, in the ventricles, intracerebral. You get the idea at this point. But in essence, these are going to also be associated with cerebral aneurysm and hypertension, things that might increase your chances of having aneurysms forming and rupturing. And we have to also remember to apply our Monro-Kelly doctrine in this case, because whenever the volume of the inside of the skull increases, something else has to go by comparison. And while that can occur as a result of reduced blood flow, which might create a local stroke as ischemia to a certain area applies, we might find CSF leaks out, or if its drainage is obstructed, we might find equally that we find hydrocephalus, that the ventricles expand with the CSF that's accumulating and not draining anywhere. But of course, the one that we're most concerned for, and the one that definitely looks the most exciting on our imaging, is going to be our various herniations, such as the subthalassine one, which is beneath the falx cerebri, the transtentorial classes of herniation, uncle being one that just refers to the lower portion of the temporal lobe herniating transtentorially. It's just an alternative, it's a hyperspecific term for a hyperspecific example of transtentorial herniation. And of course, tonsillar is one of the more dramatic ones, where we find coning through the foramen magnum of the cerebellum into the foramen magnum. Any one of these is life-threatening. Any one of these requires urgent surgical intervention at the earliest possibility. And these are something that you should be aware that is quite a high risk when we're talking about long-term intraparenchymal bleeds. So I've got this management of head trauma information from NICE, and I'm going to say that a lot of this will not be things that you have to be have memorized for your exams, because what, as interesting as this may be to look at and to understand the notions behind, the core concepts you need to take away from this are that we're going to be assessing degrees of consciousness and visible injuries in a patient after a head fracture, and determining based on after a head trauma even, and determining based on that whether we are suspecting any kind of notable hemorrhage and treating accordingly. You can go over these in your own time if you like. It's definitely interesting. It's definitely going to be useful for you much later on in your career. It's not necessary at any point during this current stage in your learning. What you might want to know, however, because some of these are going to be relevant to you in some ways, if only for suggesting things as an alternative, what the neurosurgical interventions might be. So we have a few different classes for the extraaxial and intraaxial ones. For the extraaxial ones, we have craniotomy or trepanation. It's also called trephination from a different root of the word. There are lots of spellings of it. Some of them are not even wrong. And this example on the right, funnily enough, is from 3500 BCE. This patient actually survived quite a while after the procedure occurred. So this is actually one of the oldest surgical techniques that we have on track. We might also find that through this craniotomy hole, which may be used to relieve the ICP by releasing some of the local fluid, we might also need to aspirate some of it using the appropriate equipment. We might also apply drugs afterwards, and these will vary quite a bit. I've given hyperosmotics, which will reduce the fluid volume and therefore reduce the ICP. We might provide them anticonvulsants to prevent the seizures that we might be worried for. We might also want to consider others, such as antiemetics, in case they feel nauseous on waking up. For intraaxial bleeds, we're going to be looking at far more drastic measures, because obviously this is going to be interventions within the neuromaterial itself. So you might consider coiling or clipping. Coiling being providing a coil to the blood vessels to block it up. Why might we choose over clipping? Well, clipping is faster, but coiling, by placing a metal coil in, we allow the blood time to displace from the aneurysm before we block it off. And therefore we might reduce the chances of it being overinflated and rupturing later on. So there's pros and cons to both coiling and clipping to block off our aneurysms. We might also be using a catheter to block or dilate the blood vessels, depending on how we apply it. If it's possible to even aspirate, we might want to aspirate. And in the most extreme cases, you might even go with a craniectomy, removing part of the skull to allow the brain to expand in size as needed to maintain life. So I'm aware that I'm running quite close to the time frame. Thank you so much for listening. If you do have any questions, perhaps you're more than welcome to email me or to message me by any other means. But I don't think we really have time, so I'll just pass it on to the next person, who is Kat. So thank you very much, and I'll see you all soon.